Thank you for joining me today. I'm Dr. Juliet McGrattan, and I am really excited to have a special guest today. We've got Dr. Katy Munro. Now, I specifically asked Dr. Katy Munro to come and join me because I really wanted to talk about the topic of headaches, and she is a specialist headache doctor. She hosts a wonderful podcast called the Heads Up podcast, which is for the National Migraine Centre. And I'm going to ask her a little bit more about that later. And she's also author of a great book called Managing Your Migraine. So we're going to talk about migraine, but we're going to talk about all sorts of headaches, running and hormones, etc., etc. So I hope you can stay and join us for this little chat. And just say welcome, Katy.
Thank you very much for inviting me. And I'm really excited because I was starting to do running and found your book and read it cover to cover. And that was an inspiration for me to sort of push myself and treat myself gently, but also keep motivated to keep running. So yeah, it's really lovely to be on your podcast.
Oh, that's wonderful. Thank you. And thank you for the feedback on the book. It's lovely when you get some feedback that you've made a difference to somebody, and also that we can share tips between us, both as doctors ourselves. So wonderful.
Definitely.
Right. So headaches, that's the topic. Obviously, that's your specialist area. There's so much we could talk about, but I think maybe I would just like to ask you, what types of headaches are there and what do you see in your specialist clinic?
Okay, so we divide headaches into primary and secondary headaches. And because I work at the National Migraine Centre, you might think that we only see migraine. And on the whole, we do see the majority of our patients have migraine, which is one of the primary headaches. But we do also see quite a number of people who have a much rarer kind of headache called cluster headache. And unfortunately, we see quite a number of people who have had migraine and overused medication because they're very desperate to get on top of their horrible attacks. And so we see quite a lot of medication overuse headaches. So medication overuse headache would be a secondary headache. The other kind of secondary headaches that you might come across would be things like a thunderclap headache or a headache, sadly, from infection like meningitis or a tumor, that kind of thing. We don't tend to see those in our clinic. Those tend to either present to GPs or go off to casualty or through to neurology. So on the whole, we're seeing a migraine. We see quite a number of people who have been told that their headaches are due to either sinusitis or possibly tension and stress, or sometimes it's probably just your age, you'll grow out of it. So but actually most headaches are migraine, and so that's the majority of what we see.
And you mentioned some of the more scary things there, like infection and tumors, etc. What should we be worried about? What is there when you hear somebody's story that makes you go, oh, I think this might be a bit more than migraine? Or not that migraine isn't serious, but what might be the dangerous symptoms that would alert you that you might need more tests?
So really, if people have never had a history of any sorts of headaches and they suddenly get an onset of headache, especially if it's feeling like what we call a thunderclap, it comes on really, really suddenly, like sometimes described as being hit by a baseball bat on the back of the head, that needs you to go to casualty. And that can occur just out of the blue, or it can occur during sex. And sometimes people are a bit shy to talk about that. But we would always encourage them not to come to us, but to go straight to casualty with that, because that needs checking out in case there's any element of a bleed on the brain. If you were having an infectious cause, then you would very often have other symptoms like fever or feeling generally unwell, a sudden onset where you haven't had a history of headaches before. If people are over the age of 50 and they suddenly start getting headaches and they've never previously had any kind of headache, then I would always say go and get that checked out. Most of the patients that we see have a long history, and if you ask careful questions, they often suddenly realize that they've had migraine attacks since they were children. What we would say to those people is we would only worry about your headaches if they change. So if you were suddenly getting a paralysis where you've never had that ever before, then obviously you need to get that checked out. So there's a lot of things. Mainly it's about changing, it's about how old you are, it's about the other symptoms. So people who are developing brain tumors do get headaches sometimes as a symptom, but they also, when they get examined by their GP or neurologist, have other neurological signs that we can pick up that are very common in people having brain tumors. With migraine, you don't find anything when you examine people. They just have a normal neurological examination. So lots of clues to help us. And also the fact that migraine is so common that actually makes us really not have to worry too much about those other much rarer kinds of headaches. So I would say to anybody, if you're getting recurring headaches that put you out of action for a while, maybe you can't do your daily activities for anything between 1 and 3 days, if you get a bit of light sensitivity, if it's worse when you move, or if you get a bit of nausea and vomiting, then you've probably got migraine. It's almost definite that you've got migraine. It's something like 90% or more if you tick the box for all of those questions. And we often ask about family history because we know that people with migraine have inherited some genes that make them more likely to get migraine attacks. And so often they'll say, well, yes, it was my mom or my grandmother or my auntie used to get migraine attacks or still does. And drilling down about family history, it gives a very strong clue as to whether we're dealing with migraine. But even if people don't know their family history, somewhere back in the midst of time, there's usually some relative who just never spoke about it, put up with it. Lots of people do.
No, that's really helpful. That's really reassuring, because I think sometimes people do fear the worst, don't they? And in the middle of the night, particularly, you suddenly do come up with these diagnoses of tumors and things. And so to know that the majority of the time it is not that, and it's much more likely to be something like migraine.
I mean, we're talking up in the 90%, people that go to consult with a GP about headache, over 90% of them will have migraine. So
you mentioned some of the kind of symptoms there. How would most of us know whether it's just a bad headache or a migraine?
So this is one of the bugbears of me, because I think of migraine, I have a little phrase that I keep elongating. So first of all, it's a genetic, whole body, neurological condition. And I sometimes add in the word a spectrum condition. So migraine is caused by a combination of genes and environment. And that can be internal environment or external environment affecting those genes and the way that they affect us. So migraine is the disorder. One of the symptoms is headache. And the headache with migraine may be really horrendous, or it may actually be quite mild. So that's why I say it's a spectrum disorder. Some people don't even get headaches. Some people have migraine aura and they see sparkly lights or blurred vision and they don't get a headache with it. And they're like, what's going on? Some people get dizziness as their most bothersome symptom. And so there are a variety of ways that migraine genes can be expressed in the body, but I prefer to talk about migraine attacks rather than migraines, because migraines, how your migraines implies that these are just bad headaches, and I think it's quite misleading, because we wouldn't say to people, how are your asthmas or how are your epilepsies? We would say, how are your asthma attacks? Because we know that asthma comes and goes in attacks, and it's the same with migraine. So migraine gives a whole selection of different symptoms, some of which I've touched on, and there are many others that I haven't even mentioned, but we can go into in a bit more detail. But I think being too focused on it's just a headache or it's just a bad headache means that a lot of people are either dismissed or stigmatized when they're talking to friends, family, or sadly even some healthcare professionals about their migraine, because there is a bit of a misunderstanding about this condition, I think.
Yeah, that's that terminology mentioned there. That's something I learned from you. I think it was last week when you posted something on Instagram stories, I think, saying, don't say migraines, say a migraine attack, because migraine is a condition, and like you say, you wouldn't say how are your asthmas. You would say how is your asthma, the condition itself. So I'm really grateful for that, because I thought I knew a reasonable amount about this topic, and actually I haven't even got the basic terminology right. So I'm really going to try, and I was trying to think in the book that I've written, but the books that I've written, how I've referred to it, and I'm sure I haven't referred to it appropriately. So I've really taken a learning point there, and you can pick me up in the future if I do get it wrong. But I think that just shows that it is a condition, like you say, with a big spectrum of how it can present.
I think the other thing about thinking about it as an attack is that people very often, when they come and see me, they don't realize that there are 4 phases that we talk about through migraine attack. So the first phase, that prodromal phase, can last anything up to 2 days. And that can be when the changes which irritate the brain are happening. So that might be that poor sleep or skipped meals, or it might be stress, or some people are quite sensitive to weather changes. I seem to be getting that myself personally. When it rains, I get more headachy. And so that 2 days is the prodromal or premonitory. You get a premonition, but you don't really know that you're in an attack. Some people get lots of yawning in that phase, or feel exhausted, and then here we go. And then the more so about a third, 25% or 30% of people get aura. So that's the second phase. The vast majority of people don't get aura, and that's the zigzags, flashing lights, blurred vision. Some people get sensory aura, where they smell funny things like cigarette smoke or diesel when there isn't anything around. And the third phase is the more typical, what people would call the headache phase. I tend to call it the impact phase, because again, sometimes it's the dizziness that bothers people more, or the vomiting has already started, and but the headache tends to go on then with anything up to about 3 days. And then there's the kind of hangover phase, where the main phase is finished, but you still feel absolutely steamrolled. And some people find that that's even more troublesome, because they're back functioning, but not at their proper level of functioning. They're still dragging themselves around, but their headache has lifted and the other symptoms are dwindling. And that can be another day or so. So a whole migraine attack is not just the headache bit, it's the bit before, the bit after, and all the stuff that comes with it.
And I guess that leads into the treatment for it, what to take at the different stages.
Yeah. So the real good advice is to take the right treatment and get it in the right place at the right dose at the right time. So lots of things to get right. Sometimes I hear patients coming and saying, oh, my doctor's given me this medication and they said it's really strong, so wait until your migraine attack is really bad. And that's the opposite to what we say. So I like to think of it as a snowball. So if you think of squashing a snowball, you don't wait until it's got enormous. If you want to squash it quickly, you jump on it fast. And it's the same with the migraine attack. So for an acute attack, and obviously everybody's individual, they need to find the recipe that works for them. But the main combination is an anti-sickness tablet, even if you're not feeling sick, because there are some anti-sickness tablets that push the stomach contents on. And one of the things we know is that the migraine attack is stopping the gut working properly. So if you just take painkillers, they sit in your stomach, but they're not absorbed. So we always advise people to take an antiemetic, which could be domperidone or metoclopramide, and there are several available that largely on prescription. Then the painkiller of choice, so that might be a high dose of ibuprofen or naproxen, or even soluble aspirin. Obviously, if people are safe to take those, need to double check if you're not sure. Paracetamol, not so great, but if you can't take any of those other non-steroidal, as we call them, painkillers, then soluble aspirin can be magic for some people, especially people who get aura. And then the third thing is a triptan. So 3 things: anti-nausea tablet, a painkiller, and a triptan, which is, there are 7 different triptans. And I often find that people have got stuck on one doesn't work very well, gives them side effects. And so they've either given up on it or they're just really struggling. So I say to them, go back to your GP and ask again about the different triptans, because what we're finding is that individual people are very individually responsive to the different triptans. And of course, there's no tests. We can't do a little swab or do a little blood test and say, well, this will be the one for you. We just have to try it and see which one suits them best. And the triptans fall into two groups, and often people don't know this. Some of them are short-acting, but work quite quickly. Others, there are two others that are longer, much longer acting, but they start to work a bit more slowly. So again, it's about what you need for your particular migraine attacks, and how quickly you want that to work. Because obviously, if you're busy going off to work to do a presentation, you need something quickly. But if you're having, as a lot of women do, especially coming into the perimenopause, they have troublesome attacks around their periods. And these can go on for 2 or 3 days. If you have something that's short acting and runs out, then you get a rebound headache the next day. So you may do better with one of the longer acting ones. Mm-hmm. So there's quite a lot to talk about with migraine. As I often say to people, you know, if you ask me about migraine, I can be here for hours.
Well, you did mention something in there that I did want to speak about as well, actually. And you said about the perimenopause, and I'm just wondering what the link is between hormones and migraine.
So we know
why that link's there.
Yeah. So we know that 3 times as many women as men get migraines, but before puberty, boys and girls get migraine the same amount. So boys and girls can get migraine. Like my youngest patients are 3 and 4. And what happens at puberty? Hormones. So if you think of the genes for migraine as setting the brain to be more sensitive to change in all its forms, internal change and external environmental change. So internal change, one of the biggest ones that affects women, of course, on a monthly cycle is fluctuations in hormones. So when women are going into puberty, when girls are going into puberty, they begin to have these cyclical changes. Now, that doesn't always affect women. And if the cycles are regular and they're not too sensitized and things are going along fine, they may not get menstrual related attacks. Although I see an awful lot of women who do say, oh, they're worse around my periods. But as we get into the perimenopause, estrogen levels are going all over the place. So sometimes they're down a bit, sometimes they're up a bit, sometimes there's months where people don't have a period, then they come back again. And because it's not that nice, smooth reduction in estrogen that you might have thought that the body would do, but it's all over the place like a roller coaster. And that is a very powerful trigger. But of course, people in the perimenopause may also be having all sorts of other changes in their lives. So they may have other health problems, they may have issues with family stresses or work, career changes. Often with the perimenopause, sleep is disturbed. And of course, we know that the brain needs regular sleep, and particularly the brain of a person with migraine. So anybody who is having broken sleep or extended sleep, having a lie-in is a really bad idea if you get migraine. If you have migraine. So I feel really cruel when I talk to teenagers about this, because I'm saying to them, well, you know, you wake up for school at 7 or 7:30 every morning, Monday to Friday. What time do you wake up on a Saturday? And they say, well, I maybe stay in bed till 11 or 12. And of course, they're much more likely then to get a migraine attack a day or 2 after that. But it's the same with women who have, you know, we often have broken sleep, don't we, for lots of reasons. It may be small children waking us up, or it may be that we're just getting hot flushes because we're becoming perimenopausal, night sweats and things like that. So controlling all the changes that we can control is really important. We haven't talked about exercise, but I think, you know, again, in the perimenopause, some people think, oh, I better start to get fit because you may start to put on a bit of weight or whatever. And they may find that exercise is helpful, and it's such a good thing to be doing, but occasionally exercise can trigger migraine attacks because of the changes in either posture or possibly blood sugar levels or dehydration and that kind of thing. So change, I think, is a key word, and finding routine as much as you can to control the things you can control can be really, really helpful. I personally never had any migraine attacks and never had any headaches I can remember until I was in my early 40s and suddenly started getting horrible Wednesday migraine attacks. I don't know, why Wednesday? I was a GP, I was a partner, it was a busy practice, I never got lunch, I was rushing about, I had small children, you know, and it took me a while to twig. But that, you know, going forwards, I now see vast numbers of women in that sort of age 40 to 50 age range who are going, hang on a minute, my migraine attacks are really getting worse, what can I do? And there are loads of things that we can advise.
So some women may have never had any cyclical hormones linked to their menstrual cycle, migraine linked to their menstrual cycle, but then when they come into the perimenopause, like you mentioned yourself, they can out of the blue, kind of out of the blue, start developing migraine.
Yeah, that can happen. And also, if you've had menstrually, it's hard to say that, menstrually related migraine as a younger woman, you're more likely to run into problems around the perimenopause. And if you've even just had more occasional migraine attacks as a younger woman, then when you get into the perimenopause, what sometimes happens is the attacks change in their nature slightly. So we hear people saying, I get dizzy now, or I never used to get dizzy. So that kind of horrid swimming feeling comes as part of the brain activity from the migraine attack.
And like you said, I mean, there's so many changes going on. So it's not the absolute level of the hormones themselves, but the way that they're fluctuating and going up and down that causes the trouble.
Yeah. So the goal is really to reduce the change.
Yeah.
So reducing the changes in your lifestyle can mean making sure you never skip meals, maybe adding in a bedtime snack, having a lot more protein and fat in the diet and less carbohydrates. Although around exercise, carbohydrates can be all right because you need the fuel to be burned up. But then hormonal changes, so this could be by taking the oral contraceptive pill. If you're taking that can be a sort of early form of HRT almost, when women are in their early 40s and need contraception, or it might be having a Mirena coil fitted and then having topical estrogen. So we know that having estrogen through the skin seems to give a smoother blood level. There's no risk for anybody who's having HRT for their perimenopausal symptoms, even if they have migraine. We are cautious with women who are just having contraception at a younger age if they have aura, and we're cautious not to give contraceptive pills that contain estrogen. But once you're hitting the perimenopause, then it's actually absolutely fine as long as we're using that transdermal form of estrogen.
That's really interesting and important, I think, isn't it? Because they may have gone through life being told you can't have the pill because there's a risk of stroke because you've got migraine with aura, but to know that actually things do change when you get to that later stage in life, I think that's really important.
Yeah. Yes. I think, although I think it's not taught very well in our medical training. It's not taught very well even in GP training, because there are so many other conditions that GPs and doctors generally have to know about. But I think especially recently, awareness of migraine is improving and managing it is not that complicated. There are some basic rules to get right, the lifestyle, getting a good acute treatment and making sure that you're not overusing that. So using those acute treatments on only 10 days in the month to prevent medication overuse headache. And then also, I think we as doctors are sometimes to blame for not starting preventative medications early enough. So people are taking acute medications and having more and more attacks. And we need to be jumping in a bit quicker. But it's an exciting time to be working in this field because there are so many new developments coming through.
I was going to ask you about that actually, because I keep seeing things, studies looking into migraine, and this could be the new treatment for migraine. Is there anything to be excited about at the moment?
Definitely. In the past, with preventatives, we've mainly borrowed things from other conditions. So we've used anti-epileptics or anti-blood pressure medications. We've used things like propranolol or amitriptyline, which are never specifically designed to treat migraine. And so they do work. In some people, they're amazing, but they don't come specifically for migraine. And so they come with a lot of side effects, and you have to take the best way to try them is to take an increasing dose until you get to the maximum tolerated dose, and then hang on in there for 3 months because they work slowly. And people have to be patient, and it is worth it in some people, but again, we can't look at you and know which one will be the one for you. So it can be slow and rather dispiriting and frustrating process. But the new kids on the block are the monoclonal antibody injections. So these are injections that you give yourself like an EpiPen. So you press the button and it injects the dose once a month. And what happens with those is that they bind to the neurochemical, which is one of the pain triggers in the brain, or they bind to the receptor. I sort of think of it like a plug and a socket. So two of them bind to the plug, the other one binds to the socket and stops that pathway from activating. So we are hearing very, very good feedback from patients who've started these. We hear the words life-changing now from people who've had chronic migraine for years and have been struggling. They're very well tolerated. They sometimes give people constipation. Which would you rather have? Constipation or a pounding horrible headache every single day? So the constipation is usually manageable anyway. They sometimes give a bit of injection site reactions. That can be one of the things. But on the whole, people come back and say, I just feel so much better. My acute treatment's working better. I've got some crystal clear head days. We talk about a crystal clear head day is a day we have no symptoms at all, because often people with migraine are quite stoic and they go, oh yes, I had 2 attacks last month. Well, how many crystal clear head days? Well, I don't really get those. I just put up with the other days, you know. People with migraine are brave and stoic, and they often are just not talking about it or sharing it with even with their close friends, you know. So I had a lady who started on one of the anti-CGRP drugs, and she said, I've had 30 years of migraine and I never told my friends. And now I'm so much better and I'm socializing and I've had a better Christmas, and she was so happy. So, you know, so are they available on the NHS? The answer is yes, but. So yes, they are, but you have to see a headache specialist, and you have to have tried, at the moment, you have to have tried 3 of the tablet preventers before you'd be eligible.
Okay.
So we always have to caution people. We can prescribe them privately, but they are quite expensive. So at the National Migraine Centre, we're a charity, so people can refer themselves to see us, and we ask them for a donation to keep us running. But if they want the prescription for the anti-CGRP drugs, we can provide that, but they do have to pay the cost of the drug. But the other thing is, the other new kids that are coming soon, hopefully, are tablet forms of CGRP blockers. So these are already out in America, but they're taking their time to come over to this part of the world. So we're hoping that any second now we will be able to prescribe them. Trouble with any new drugs, as you know, they're always expensive. And so it's finding out, you know, how we can afford that as an NHS, who it should be targeted for. And at the moment, all the individual hospital trusts are making up their own protocols. So we're hearing from some patients that they went and they explained their story and they got a prescription, and other patients have been told, well, yes, you are eligible, but you'll have to wait a year. So it's a bit patchy at the moment. But
positive, you know, that there are things. I mean, I have 2 family members who really have very significant migraine, and you know, for many, many years, one of them. So just to know that there potentially are things coming along that could be life-changing for them is wonderful to hear.
The other thing I need to probably emphasize, it's not all about drugs. It's, you know, there are also neuromodulation devices, which are quite interesting. So that's a long fancy name really for something that basically means it's not a drug. So there's one that you stick on your forehead and it gives you electrical impulses, a little bit like a TENS machine, and that's called a Cephally Dual. There's another one coming along soon, which you wrap around your head. There's another one which is a magnet, gives you magnetic pulses in your brain. So there's other ways of treating migraine that isn't just involving medication. And then there are things like supplements. You know, a lot of people do quite well if they take magnesium supplements, or vitamin B2 has got quite good evidence for preventing migraine attacks. And some people that I see would say, well, I'd much rather take supplements. It's really important to have your vitamin D level correct, because low vitamin D seems to make the likelihood of getting chronic migraine a little bit higher. And there's a couple of other supplements that have some benefit in some people, but I have to always say in some people, because there's nothing that is guaranteed to help everybody at the moment, unfortunately. Maybe we will get there, because there's lots of research going on. That would be really great.
And can I ask you, in terms of running, because obviously running's particularly what I like to talk about, do you see being active and exercising, such as running, as part of the management of people's migraine attacks, or more as a trigger and an issue and a problem for runners?
That's a really good question, because I think the answer is yes to both of those, really. And so we know somebody did some studies on people doing exercise who had migraine, and they discovered that mild to moderate regular exercise, if you can do something 3 times a week, gently, you know, get moving for 30 minutes 3 times a week, that tends to improve migraine. If you do high intensity exercise, and you just go for it, really getting your pulse rate up, often that is a trigger for people. So but I think it's more complicated. I think we don't really have enough research to know why quite that is. Now, is it the posture? Is it, you know, people are straining their neck and shoulders because they're lifting weights? Or is it that they're hyperflexing if they're cycling or swimming or whatever? Or is it that their blood sugars drop down, they haven't been eating before, or they've got dehydrated before or during exercise? Or is it just the change in body temperature from exercising, or the pulse rate? We don't really know, but I think as a general rule, exercise is great. We all need to be doing more of it. You know, they say, you know, motion is lotion, don't they, or phrases like this. We all need to be exercising more, even if it's just simply walking. So if people say to me, well, I've tried to exercise, but my migraine attacks at the moment are coming so easily that every time I try and do any exercise I get triggered, then I would say start very gently but still move. So movement like Tai Chi or yoga, keeping your flexibility, doing some gentle strength work if you can, may be manageable as you grant. And I think we always have to think holistically with migraine and look at every aspect. But I think, you know, for me personally, I started running. I've been doing quite a lot of exercise. So I swim and I cycle sometimes, not when there's hail like there was today. So I started gently. I started doing the Couch to 5K and got up to the end of that program, which I highly recommend to people, and thought, right, now I'm going to do a park run. And then lockdown happened, and so I didn't really do much. But starting back, once things had improved a bit and we could get out there, I thought, right, this is my target. And I've started, as you know, Juliet, doing a park run. So I'm really enjoying the experience. And actually, I'm sure that it has made a difference, just to do something gently. And there's something for me about the endorphins that you get. That if I have a little bit of a headache and I do some exercise, it seems to help clear it. The other type of exercise, and there's a podcast episode on migraine and exercise, and I spoke to a guest of mine who had tried cold water swimming. And so people, and it's quite a cool thing to do, excuse the pun. So I know a lot of people will try cold water swimming. Obviously do it with caution, make sure you're with somebody, don't just jump into a freezing cold plunge pool without taking some care. I tend to inch my way into the cold Cornish Sea when I'm doing my cold water swimming. But there is some research going on into why cold water swimming is so good at releasing endorphins, and that those endorphins are those natural body painkillers, and they can seem to help some people who have migraine. And certainly Beth, who I interviewed, found that it had really helped her. I mean, I think getting out into nature is helpful too, isn't it? Blue therapy or green therapy of walking along a beach or walking through woods, and just getting out there is really good.
One of the things that I've heard people say is that one of their triggers for migraine is stress, and that if they can continue running regularly, it helps them to manage their mental health, which then has a knock-on effect to reducing the frequency of their migraine.
Absolutely. What I have a quarrel with is when people with migraine are told, oh, it's probably just stress. It's never just stress, but it often is added to, you're aggravated by stress, because if you think of it, stress is also a time of change. So we'll have stress hormones, cortisol, we may not be sleeping very well, we may have muscle tension, and we know that the neck and shoulders send pain signals to the brain to trigger migraine attacks, and we know that migraine attacks send pain signals to the neck and shoulders. So there's a bi-directional relationship. So again, sometimes I have patients who say, oh, I was told it's nothing to do with my neck. It is to do with your neck. And some people get more migraine pain in their neck and shoulders and not in their actual head. So I think, yes, I think that stress is definitely worth looking at. And, there are various ways to do that. One of the easiest ones I recommend is expressive writing. So you just basically sit down with a pen and paper and you write everything down for 20 minutes. And you do that for 4 days in a row. And there's some studies that show that was really helpful for people who are going through difficult stages, who are feeling very stressed, who've got stuff to deal with, either from their past or coming up. So expressive writing, simple breathing exercises, there's slow relaxation. I think you've put some of those in your Run Well book. I seem to remember there's books about your breathing and calming your breathing. We know that anything that does slow exhalations will improve the parasympathetic nervous system, which will help to reduce the migraine attacks. And then things like meditation or yoga, there are lots of apps now that I recommend to people, so things like Headspace or Calm, lots of free ways to meditate, either doing by yourself or going to groups. I think, stress management is really helpful. And of course, one of the things we hear from patients, and I'm conscious that this time of year, the teenagers are telling me this, stress around exams and schoolwork and things like that. And it can really heighten their attacks. And then they worry about getting an attack before they've even got one, and that makes their attacks more likely. So putting in place a good plan so that you have the confidence that you can manage an attack even if you do get one, that helps that anxiety to reduce. So we know that people with migraine are 9 times more likely to have anxiety than the general population. The other thing, just going back to exercise sort of briefly, the other thing that just slightly links in is we know that a large number of people with migraine are also hypermobile. So if they're doing exercise and they're getting dislocations or they're getting injuries or joint pains, then we also, in our clinics, we're often saying, well, do you consider yourself to be hypermobile? Is there a family history of hypermobility? And that can link in with blood pressure changes when they stand, or pulse changes, POTS, postural orthostatic tachycardia syndrome, is very common in people with migraine, and mast cell issues. So release of histamine can be very common in the perimenopause as well. Women get more histamine intolerant, and that may be part of the picture. So we are very lucky at the centre that we have a much longer time to deal with all the different aspects of a patient's story and how we can help them. It often takes me anything between 45 minutes to an hour to take a history and formulate a plan. And so I do say to all GPs, tell your patients they can come and see us, because you've only got 10 minutes, and we've got longer, and we have more expertise in managing migraine. So we're very happy for people to self-refer. We don't need letters from GPs. People can just go on our website, fill in the booking form, and we'll take it from there. And we do recommend GPs to prescribe, because otherwise patients have to pay private fees. But it's really
so it's a National Migraine Centre, am I right? Have I got that right?
Yes, the National Migraine Centre website is just newly relaunched, and it's very simple. It's nationalmigrainecentre.org.uk. So
brilliant, because I'm sure there'll be people listening who are like, right, because as you've really explained so well there, it is not just a headache. And that's such a holistic view of all the many things that you can be doing yourself that are nothing to do with medications, but it's so much more than just popping a couple of painkillers when you get a headache. So that's really, really useful, and I definitely know lots of people are going to be wanting to take you up on those appointments, prepared to be busy. And I wanted to mention your book as well, Katy, because Managing Your Migraine. Tell us a little bit about that. Has that got lots of that information in it?
Yes, it has. I was so thrilled to be asked to write it. It's a Penguin book. It's part of the Penguin Life Expert series. And what I was hoping to do was to give people a practical self-help book that they could read under the chapter headings. If you want to learn about migraine and exercise, there's a chapter. If you want to know about migraine and hormones, there's a chapter. If you want to know about the acute phase or the preventatives, there's a chapter on that. And there's a section on migraine at work, because often workplaces are not necessarily up to speed on how they can help people with migraine. I think we all need to be raising awareness that employers can do quite simple things, and that if you have chronic migraine, you can be classed as having a disability, and that can really help people when they're negotiating about sickness policies and things like that. And there is a chapter on migraine in children, because I'm also very passionate to make sure that children get good advice, because too often I give a talk to the general public about migraine, and people come up to me afterwards and say, I didn't realize those tummy aches that I was getting as a child, that was migraine. I used to get these really bad headaches and be sick, but not very often. Nobody told us that it was migraine. And it is quite common in children. About 1 in 10 children will have some migraine, but usually it's manageable. Usually it's milder. We don't see too many who have chronic migraine, luckily, but getting the knowledge and understanding about migraine and empowering people to manage it better is why I was really thrilled to write the book.
Yeah, that's wonderful. And where can we listen to your Heads Up podcast? Is that on all kind of usual podcast platforms?
Yes, it's on Spotify, Apple, Castbox.
Brilliant.
Podcast. I've lost track. There's so many podcast places. Or you can just go on our website and it's all on there. We've just started series 5, and that was with an episode on brain fog, but we've covered all sorts of other topics. We tend to have an expert guest and also patient stories. So at the end of each episode, we try and have a patient telling their story about how it's affected them. There's an episode called Migraine and Men as well, because we don't want to leave out the men. A lot of men put up with migraine attacks, not realizing that's what they're getting. So there's a whole episode dedicated just to men.
Brilliant. You're like a fount of knowledge. It's amazing. Thank you so much, Katy, for sharing all of that with us. I know that's going to be really, really useful, particularly to the perimenopausal women and the runners, just to know that what the situation could be, whether it's a trigger, whether it can help it, whether it can make it worse. I feel like we've got so much great information and value from you. So thank you very, very much for joining me.
You're very welcome. And as I always say to patients, this is only plan A. There are other things we haven't even mentioned, Juliet. So
yeah, definitely.
You won't have tried it.
Well, despite having my phone on airplane mode, you've probably heard it pinging, so I'm sorry about that. It is on airplane mode. I don't know how these things break through, but anyway, it's been lovely to speak to you, and yeah, I'll speak to you again soon. Thank you so much.
Brilliant.